and mentally.
Sorry.
Oh, physically and mentally absolutely buzzing and ready for any challenge at all. Let me just move that away. I've got a sign on the screen. So yeah, so the talk tonight then, I want to do two aspects as well about fitness in your 40s. Physical fitness, which is the first part of it. And then the second part is the sports massage therapy that I provide at Lymm Osteopathic and how that supports fitness and how I help my clients there on their fitness journey. So physical fitness, I want to look at what it is, what we mean by that. Why it's important. I want to look at the key benefits to us in our 40s, 50s and upwards as well. And also the barriers and the evolving challenges that we face in this phase of our lives. And also I want to give you three really good key tips that you can take away before I talk to you about the treatments that I do at Lymm. So very quickly, definition of fitness. We all know, I'm sure, what fitness means. So I'm not going to go on about it too much. But we all know, don't we? It's about the body, the ability of the body to perform everyday essential tasks. We all know to keep our blood pressure regulated, good resting heart rate, good nutrition, good exercise. But what is often overlooked is the mental, social and emotional side of it. So four very unique aspects, but the physical exercise really does play a key role in supporting all four of them, really, to be honest with you. So why is fitness then especially important for us as we hit our 40s and 50s? Well, for the body, I'm sure many of us are aware, it's been well documented of the key benefits. We want to stave off disease, obesity, we want to help against diabetes, it's good for our joints. And we're all familiar with the, if you don't use it, you lose it principle as well. And of course, as we age, we lose our muscle mass and bones aren't quite as strong. We don't spring out of bed in the mornings, do we? Like we did in our 20s, like gazelles. Although maybe some of us do. But it's really important, though, the exercise that we do, of course. But what do I mean by exercise? So there's all sorts of different things you could do. But what I mean we should be doing is resistant-based exercise, and we have our cardio as well. And it's really good to have a balance of the two for your physical exercise. So what do I mean by resistance exercise? So in a gym-based setting, I'm talking maybe dumbbells, kettlebells, resistance bands, or outside of the gym, perhaps body weight or anything that provides a good challenge to your body. Even shopping bags on a regular basis is a good challenge to your body, your bones and your muscles. Combine that then with a bit of cardio. You're talking walking, jogging, or anything you enjoy. The two together then is a really good package and becomes really, really key in helping us. And then, of course, it's really important in 40s, 50s and upwards for our minds as well. Because I'm sure you can identify there's times when we have those mornings when we've got big black clouds over our heads. You know, we're tied up with stress and anxiety, and it's just overbearing as well. But you can do 30 minutes activity in the garden, and you just come out of it the other side like a new person. It's quite incredible. You've got the release of chemicals in your brain, like serotonin, and all of a sudden you can breathe, you can smell and breathe in the fresh air, you can sort of smell the grass and see clearly. So it is incredible. So okay, so we know all this already, don't we? But if we know this, why are we not always doing it? What are the challenges and barriers that we have in our middle age? So the barriers and challenges, I just want to quickly go through and see whether you can identify with any of these in this phase of our life. Are things like friends, family, maybe parents getting older, and our responsibilities change. You know, maybe perhaps you're in a caring role, looking after elderly or sick parents. Perhaps the most rewarding thing you'll ever do, but very dedicated with your time, so you don't have time for yourself. Of course, your kids are older at university, or maybe playing football, so you're running around every evening, taking them here, there, and everywhere as well. You've got more responsibility at work, working from home, all the hours and everything else, and all the stress that goes with it as well. And also, we are the meat in the generational sandwich, aren't we? We've got, of course, one side we've got the kids, and on the other side we've got our parents and the older generation as well. So to be able to not just manage these challenges, we need to be in the best physical and mental state that we can possibly be. So how do these barriers then prevent us from the exercise that we really, really want to do? I mean, can you identify with just not having no time, feeling exhausted, drained, possibly feeling guilty as well, dedicating time for yourself when somebody else needs it, if you're looking after somebody in a caring role? We also actually could feel scared. Perhaps we don't want to hurt ourselves. We're scared of injuring ourselves. We have good intentions, but we don't know what to do. And also the challenge for women as well, entering the phase of, dare I say it, perimenopause as well, and all the challenges and struggles that brings as well. So lots of barriers for us in this phase. So that's that physical aspect. What I really want to do is to give you 3 key tips then that you can take away from this meeting. I'm going to keep it nice and simple as well, that you can take away. So the very first one I'd like you to do is to just assess. Assess your own very unique situation, because we're all so different. We're all doing different things. But assess and realize that you don't have to run a marathon by next Saturday. You don't have to do all these things. Find something you enjoy and just start it, and just assess when you can do it, and just see what your own situation is. So just take a step back from your busy life and just see where you are at that moment. Second, and that links in quite well, is to, we don't always do this, prioritize you. It's easy to very much say, but very difficult always sometimes to enact. So treat it like a dental appointment, treat it like a business meeting, your exercise in the park, or your walk, or your jog, or anything like that, because consistency is key. It's great that you might be jogging, but if you're only jogging every now and again and spending lots of time sedentary, just sort of watching telly or sat around helping people, anything, you're not really helping yourself there. So consistency really is key there. So really prioritize yourself as well. So we've got assess, we've got prioritize. And then the third one I want you to take away is get support. Don't do it on your own. Enlist a friend, partner, somebody on your own wavelength that you can do it with and have fun with as well. It keeps you accountable. It could be a personal trainer as well. I've got personal training as well coming to Lymm soon as well, and it's something I'm very passionate about, helping people. And personal trainer as well can keep you on track, keep you motivated, and give you a plan as well. So that's the physical aspect of it. So what I'd like to do now is talk about the sports massage and therapy that I do at Lymm, how this ties into fitness as well, how it supports fitness, and it works in great harmony with fitness. And what I'd like to do is give you some working examples, some case studies that that will tie in really, really nicely and really back up then what I'm saying and how it works with fitness as well. So somebody who's into fitness may be in different phases. They may be somebody who wants to start exercise. They realize perhaps they've put on a few extra pounds over lockdown. They want to start their physical activity, but they've got an existing injury. And this is quite common as well. And it could just stop somebody from doing what they want to do. So for example, if somebody's got a pain in their knee, walking up and down the stairs, they're not going to start a program of walking or running or anything like that. So that's when they can come and see me at Lymm Osteopathic. So for example, I had a lady come to see me as well. She had terrible pain in her Achilles. And she wanted to start fitness. She wanted to start a program of running as well, but she just didn't even know where to begin because the pain, for example, driving, waking up in the morning was just too much. It was just all the time. So she came to see me. So the key message really with my treatment at Lymm, and it's something that runs throughout the whole practice, is that we don't just address the symptoms. We really go for the root cause as to what's causing that pain. So with her, the most important thing I did for her treatment was to get a full history, to sit her down, to let her explain exactly what had happened, the full history, and I want to know how that occurred. So for her example, she's a very busy lady, mid-40s, 3 kids, really stressful job, lockdown, and she bought a pair of these most fabulous boots that she loved wearing that absolutely destroyed her Achilles heel. So she realized this after a few weeks, but the damage at this point was done. She got rid of the boots, but she struggled all last year and the condition became chronic. So she didn't know what to do. She tried different things, but she came to see me. So she gave me the full history. So we discussed aggravating factors. We discussed all sorts of different things like nutrition, sleep, what exercise, what she was trying to do, daily routine, any other sort of factors that might come into play as well. So the treatment really is I broke this one down into 2 phases, really. When someone comes to see me, what I want to do is get them out of pain. That's my priority. Because that's what they want as well. That's why they come to see me. But what also is probably more important as well is that I don't want the pain to come back. So I broke it into 2 phases. We had phase 1, which was a calming phase, gave her the treatment, the massage. We did some sort of therapy work around the Achilles as well, a little bit of taping as well, which can really offset pain. And then some very light rehab, which I gave her. And then she'd come back to see me, and then I can slowly progress and strengthen her ankle, and also the structures around there as well. So it's kind of looking at it from the whole picture. So she's progressing really, really well. She's doing great. The pain is really eased. She's doing more things. She's starting some light exercise, and she's on her way. So it's a super, super example, and I love seeing that progress. And that's just one person, really. So I've got 2 more case studies, 2 more examples. So that was somebody that wanted to start exercise that had an injury, but you don't need to have pain to come and see me. I have many clients that come and see me. They're doing exercise at the moment. I have one chap who's running 10Ks, very busy, has a physical job. He a very busy, hectic lifestyle as well. But what he doesn't want to happen is to do too much and become injured, and then everything to completely stop. So he just comes in, sees me. We have a maintenance treatment. We just basically flush everything through. We work on the lower leg complex, and also we don't neglect the upper body. So it's kind of like a full body treatment, really, to keep everything nice and supple, moving, keep his range of motion, and it just keeps him going. I liken it to a car. Our bodies are like cars. Like, you wouldn't get in your car and drive all the way around the country and then not get it serviced or not get it MOT'd. But do you know what? With our bodies, that's exactly what we do sometimes. And then when it stops working and we break down, we wonder what's happened and why we didn't go in for that service. So this is what I sort of say to my clients as well. That was his example there, which is really, really good. And then also somebody, then the 3rd phase is somebody who is in their fitness phase, but then injury strikes and they don't know what to do. So I get this type of client come to see me as well. And this is where, again, I can really help. I had a chap come to see me, 56 years of age. He was very active, played a lot of tennis, hiking, biking. He had a very physical job again. One day he reached into the cupboard and tin of baked beans, would you believe it? He reached up and pain all the way down his arm. He lost, over time, he lost the range of motion. He had awful, if he put his elbow and arm into a certain position, he would get horrendous, like a shocking pain that he's never experienced before down his arm. He knew nothing like it at all. So his range was really restricted. He lost his external rotation, and those gave me key clues as well as to what might have happened. So again, like the first example as well, before I started any treatment, sat him down and got a full history. I wanted to maybe rule out any kind of underlying pathologies, anything that might have been a bit more sinister, get a full history. What's he been doing? Has he been doing anything that's more intense that might have brought it on? And just kind of look at it from the bigger picture as well. So 56-year-old is, from the research that I've looked at as well, is typical age for frozen shoulder, loss of external rotation and restriction in the shoulder, the pain as well, referring at the back of the deltoid here and into the tricep, are key symptoms as well. So we kind of addressed it as well, and I could work on then his mobility and gave him some mobility exercises to progress him further. So he's now looking at a steroid injection, speaking to his GP as well. So it was a really good step towards his rehabilitation as well. But the great thing at Lymm Osteopathic is that if it involves bones or alignment, I can refer to Suzette. feet or lower limb, we have Neal, who'll be talking very shortly as well. So at Lymm Osteopathic, it's the whole picture. So I'm just one of many amazing therapists that can really, really help you. So Sharon's got all my contact information there. I update a lot on my personal, my business, personal training and massage therapy Facebook page, and update with all my progress and what I'm doing there. So please follow and like my page. If anyone has any questions.
I've got a question for you, Jason. I would like to think I'm fairly active. You know, I walk to work most days, so I probably do at least sort of 3 miles walking to work most days. But I think prior to me having COVID, I was doing lots of other exercise as well. And I just feel so tired all the time, and I can't work out whether it's just something in my head or whether it is just a side effect of having had COVID and it's just going to take me a bit longer to get my mojo back. Is there any recommendations that you can think of that will help me identify what it is?
That tiredness, the way you're feeling kind of lethargic and...
I mean, I used to get up at 6 o'clock every morning and there was never any issues, you know, and this was up until February this year. And I would do whatever I was doing and, you know, my day would happen. But I just find I don't want to get out of bed at the moment. And it's the middle of summer, so it's really light and the birds are singing and all the encouraging signs are there to get out of bed and do something. But I'm just knackered.
Yeah, I know. And I think that's a real symptom from what's happened over the past year. And you really are not alone. I've felt it as well. It's motivation as well. We've spent a lot of time kind of quite isolated, I'd say, over that time. And it's kind of something that's kind of come into our almost routine that we are now. So it's actually quite difficult to almost remember where we were back before COVID. So it's really almost, it's a challenge, definitely. And I think to acknowledge the fact that you're feeling that way is the first step, and that it's not something to do with your fitness or it's a bad thing. But I think to kind of accept that that's what's happened to us now. As to what I could recommend is to almost don't give up with it, and to just try and perhaps do things. Remember, try and think back to what you really, really enjoyed or who you enjoyed doing it with, and try and get somebody to maybe give you that elbow and get you going again, and maybe train together and have fun with it. And just because I think with COVID, we've almost lost that fun element, certainly with things being on our own and things taken away from us. And I think it kind of has transferred a little bit into exercise, like the way we are isolated, you know, even group training outdoors at the moment, it's kind of like we're in different areas. So yeah, I think to try and just acknowledge it and accept that's what it is. It's not a bad thing. It's just trying to, like you say, get back to where we were and just try and find key things that you love.
Okay. I'll have a think about
Give
what
that go.
exercises I like doing.
It's not easy and it affects us all. Absolutely. It's really common. So yeah.
Yeah. Okay. All right. Thank you. Has anybody else got any questions for Jason? No? Okay. Well, we're going to move on to Neal now. So Neal, I'm going to make you host so you can share your screen with us so we can see your presentation.
Sharon, I wanted to have a question.
Oh, okay.
What I find, Jason, that's really, really hard is that I'm an all or nothing person. And I find that really, really difficult to get the balance and, you know, sort of after COVID, not being able to do anything and being demotivated. And then I'm, you know, back swimming again. I wanted to go swimming every day.
Yes.
Rather than, you know, and I know myself that I've got to let the recovery, but I just want to get on with it. You know, I find it really difficult to get the balance right. And, you know, certainly, you know, sort of because my personal fitness had really gone downhill, you know, sort of I feel so much better already. But, you know, sort of I find it very difficult to find the balance in, you know, and also my job is very physical too as well. So
Yeah.
that it's balancing all those things.
It is, it definitely is. And we're trying to do it and find that balance again on our own very much still. We're not still totally integrated and doing what we were doing before as well. So it's kind of even harder. The challenges are definitely there. But you're doing great, Suzette, with that exercise and getting out there and doing what you're doing.
It's the word is on the tombstone, she tried.
Oh no, brilliant. Keep it up, Suzette.
I've got a question too, actually.
Okay.
What's that?
Given the problems with my knees and given I've only just really started the exercises, I was doing some squats this week.
Oh,
and
yeah.
weirdly enough, even just after like one day, they do feel a little bit better.
Yeah.
So this has made me think that being idle is probably not good for them, and maybe that's why they're getting worse.
Yeah, 100%. Yeah,
Right.
absolutely. Sometimes we think rest is key, like rest up and it'll get better, but that's the opposite really. So just have some mobility to the range where if it's painful, stop, of course, but if you just go into that before it gets painful, and then that threshold should increase with added mobility. So the idea of rehab is that you can do more before pain strikes, and so that you get your tolerance to such a level when you're running again and you get no pain and you're stronger. So yeah, the rehab then, like say with the knees, rehabbing the glutes and the hamstrings as well to make sure lower leg, limb complex, all of it's really well supported and structured.
Yeah, and a few people have asked me if I want to go for sort of gentle walk run thing, and I'm sort of a bit apprehensive because I have only just started the exercises.
Yeah.
But how long do I give it before I try?
So with that one, be very careful, because it's very easy to get sort of dragged along with, because they're fit, there's nothing wrong with their knees, and well, you don't want to let them down if you go with them. So that's a danger.
Well, luckily there's somebody who got even more injured than me tagging along. So
okay. But I would say do little walks yourself, test them first. Say you could do little walks maybe around the area, say, and then maybe over a period of time, couple of days, do a little bit further and
I'm
see.
walking every day with the dog.
That's it. And then maybe increase the zone and see how you feel after. And you think, do you know what? I can do what we normally do with a walk, and then you can transfer it over and feel confident. And, and take that with you.
And last question, how long do I give it before I come back and see you again?
I think work on your rehab for a little while.
Yeah.
See how you feel. Get walking again. And then let's have a conversation. And come and see me when say a few more weeks of your rehab, and then get you in again.
Cool. Thank you.
Brilliant.
Fantastic. Right, are we going to go over to you now, Neil? Can you share your presentation with us?
Yeah. Well, before I start, I'd like to just explain a bit of background to me. As Suzette knows, I've known Suzette for over 15 years, or maybe even longer, I can't remember, when she actually came to the Salford Podiatry Clinic. At the clinic, I used to run the sports clinic, and I used to run the podiatrics clinic, and was in charge of the manufacture of orthoses. And the modules I taught was basically teaching the students about the manufacture and the principles behind orthoses and gait assessment, etc. So it was all that I used to teach, for many years. So that's my background. I retired from that in 2017, but I've always been in private practice. I used to run the private clinic at Salford University and continued in Knutsford and with Suzette's practice, which really is very good. It works very well in tandem between a patient suffering from a condition that requires some mechanical therapy, similar to what Jason said about a car. We have a car and we take it for a service. We don't look after our bodies. And so then we reach a certain point in our life, and then we think, oh, we can start running. And then we become injured. So then we start exploring avenues. And some of those avenues do work. It works well, but the massage, those treatments help. But sometimes there are underlying conditions that can result in serious problems, and which I've seen many people where they repeatedly become injured. And so then they give it all up. And some of these are very good athletes. It isn't just people that have started at 40, children, top athletes, all the same. So that's just my background. And so I just want to explain about podiatrics. podiatry and MSK podiatry. So I will now start this presentation just to sort of go over some of the aspects that I look at, or maybe Suzette and I look at, and then I tend to follow on, reconfirming or putting my spanner in and saying maybe we need that as well. And then I continue the treatment in terms of the manufacture of the orthoses. I'm saying this because it's amazing how many people don't understand the benefits of orthotic management. They just believe they can go to their boots and get a off-the-shelf device. Sometimes it works, but on some of these cases, which are quite severe, or their certain foot profile just doesn't lend themselves to a certain type of off-shelf device. A lot of people are going on YouTube nowadays, and they watch all these people telling them what to do. And it's amazing how I just get confused. I mean, like people do, they just don't know where they're going because they are being told all sorts of different things about how they should be treated. So that's the sort of the intro into my presentation. So hopefully this will work this time. Yeah. So basically I do most of my work or the fittings at Knutsford Podiatry, which is on the Mobley Road, Knutsford. My number's there and my email address is there. But I do work at Suzette's practice. I mean, it has slowed down a little bit due to COVID because obviously we're all trying to protect ourselves. I've been open during lockdown. I think Suzette has as well. We've all had to take different measures, but it's slowly getting better. So really what I do as an MSK podiatrist, I use the word MSK because in the health service, that's what they'd call me. I just consider myself as a lower limb specialist, but they all like to have titles. So it'd be an MSK podiatrist. And with that, it includes the assessment, symptoms, causes. I use causes because there could be more than one cause, and then the typical management. So this is just an overview, like with the knee pain. I've forgotten your name.
Sam.
And with the
Sam.
knee. Sorry?
Sam.
Sam. Right. You know, I see many people with knee pain, and during lockdown, I've seen so many people with a lot of these conditions I'm going to talk about in a minute. Because they've all been trying to do the 10,000 steps, they've all wanted to walk and do exercise, but then it starts to create problems. So in terms of basic assessment, when I was a student, I'll just get my little pointer out. It all goes back to Mr. Root back in the 60s. They had this theory about how the lower limb functioned. And it's all about the subtalar joint, which is basically a joint within the foot. And if that was collapsing inwards or causing a certain rotation, it would have an effect on the foot. And in those days, they used to use postings on the rear foot, on a medial post. We'd post the forefoot in different ways, all very complicated. And it was sort of basically number driven. But nowadays, I think that it's changed a little bit. Basically, we would like in theory, we would like the kneecap above the foot. So you can imagine that any forces acting on the foot would be central. So therefore, the foot isn't being forced into a position. And also, if the knee is facing forwards, the knee is acting like a hinge joint. The knee likes some rotation, but it basically likes hinge movement. The same goes for the ankle. It likes to basically dorsiflex and plantarflex, or the knee to extend and flex as we walk or run. That's why footballers become injured when they get tackled and there's twisting or rotation on the knee. So if we look at this abnormal picture, this is a lad that I treated many years ago. He was suffering from ankle pain because you can see that these feet are rolling inwards. And so it was putting a lot of stress around the ankle. Some children might get Sever's disease, which is basically a growth plate irritation. In an adult, it might be Achilles tendonitis. But you can just see the simple fact that from an observational point of view, you can see the difference between, in theory, what is the perfect limb and to somebody where they're rotating. So of late, over the past year with lockdown, the typical conditions that I've been seeing in terms of the foot, very common is plantar fasciitis. It can be bilateral, it can be one foot, but the term plantar fasciitis is just a general term. There are other aspects to it, which is not within this presentation, but they come along calling it a fasciitis or something like that. Achilles tendonitis, like going back to that lad, you can see how there is a flexion point in the Achilles tendon. So sometimes you can get pain on one side of the Achilles tendon. In the leg, we have shin pain or shin splints, very common again, where somebody starts to run and then the shins are hurting. And that is because usually where the feet are rolling inwards or collapsing, and so the muscles around the lower third of the tibia, they start to hurt. It could be a crossover point where the tendons are catching, or it can be even the point of attachment where the tendon goes into the muscle groups. Anterior knee pain is very common. That's the front of the knee, because if the foot again is collapsing inwards, it can alter the rotation of the knee joint. So there is internal rotation, and so the patella starts to glide in an abnormal position, and that causes irritation to the knee joint. Also very common is medial knee pain, because again, if that knee is rotating inwards, and then the muscle groups, quads, are going to be pulling the patella in a lateral position, and so therefore the knee starts to grumble. In the lower back, very common again, is sacroiliac pain, because again, if the foot is doing something that is affecting the lower limb, it then travels up to the pelvis and causes rotation. Again, very common is what we call trochanteric bursitis. This again is where there's something going wrong with the feet or one foot, and it can cause a rotation in the pelvis, and so we tend to get this irritation to the bursa. Also, upper back, I see people with neck pain, neck strain on one side, because again, if one foot is collapsing more, it creates a scoliosis or a twist in the back, and then it affects the neck. They have a history of neck pain. I had a young lady a few weeks ago. For many years, she's been getting neck pain, and she put it down to stress. She thought it was just because of going to school, but in fact, she had a limb length difference. One foot was collapsing, and it was creating a twist in the back, and it was causing like a twist in the neck. So she had tension around here. So no matter whatever massage was done, that was okay in the short term, but it came back again and back again. And for somebody who was 15, 16, that isn't really good. And then with the treatment I did, she's much happier now. So those are some of the symptoms. Obviously, we could go into loads and loads of symptoms. That's our trochanteric bursitis, if you're not too sure. We've got the muscles up here, and then we have the IT band. And so that bursa there is protecting this bony lump here, and that can become inflamed. And one of the typical symptoms that they always say is that when they're in bed, they cannot lie on that side because it's squashing that bursa. There was a lady I saw a few weeks ago, simply by pointing or pushing in that area, it caused quite a bit of pain. 2 weeks later, she says the pain is slowly resolving, and she's really happy. I think she was one of Suzette's patients, but I'm not giving any names away. So in terms of the causes, like Sam said, you can start to run. And some of the research that has been done is that some people can be happy to run at 3K. They do 3K 3 times a week, and the body copes with it. But then suddenly, what a mate says, let's do a 5K, let's do a 10K, let's do a marathon. And suddenly, they exceed what their body can cope with. And it usually is a mechanical reason why. They don't know that. All they know is that they're happy doing a 3K, so they think, why can't I do a 5K? But then they start to get Achilles pain, they start to get knee pain. And so usually those factors are a result of what we used to call skeletal development. and it can be quite minor differences in the lower limb. We're not talking a big deal. You know, you imagine bow legs like John Wayne or somebody else where they've got a marked bowing in the leg. That usually will cause wear and tear within the knee joint. And by the time they're 60, they probably need a knee replacement. It's quite a severe problem. You know, it's something I cannot change. Sometimes, well, at Salford University where I used to work, they developed what they call the lateral insole, which was designed to open up the medial space on the knee joint. In Australia, they've said it doesn't work, the podiatrists in Australia. So there's conflict on the types of management that can be done. But sometimes it might be reducing the symptoms in the short term, but the long term, it means they are going to need a knee replacement. And sometimes that's unilateral or bilateral. Or maybe they should just stop doing what they're doing. They think they can run like everybody else, but they don't realize the damage they're doing. And by the time they're 30, 40, 50, they've worn away the hyaline cartilage within the knee joint on the medial column. And basically it's bone on bone. So this is where assessment is really important, as I see it, for anybody wanting to take up sport, or even over 40 to start doing some exercises. Limb length is really common. Some papers suggest that the average is 4 to 5 mil, and they reckon it's over 80 to 90% of the population that can have what we call an actual limb length. You can combine that with a functional limb length, where if one foot is pronating or collapsing more than the other, then you might have 3 mil of actual limb length difference between the left and right limb, but then you have 1 foot collapsing even slightly more. So that's going to add up to maybe 5 mil. And you'd think to yourself, what's 5 mil? Orthopedic surgeons say, what, 5 mil's nothing. You can have a 10 mil limb length difference, but you try putting a 10 mil raise in one shoe. You walk around for a couple of days and you'd be in pain. So that's the difficulty sometimes we have with dealing with consultants, where they just don't want to they don't understand about how important it is to have that assessed. And it can be somebody where they've had a knee replacement, they've had a hip replacement, they've been in an accident. I've seen many people where they've had a car accident and they've broken one limb. They've had to pin it together, and then they've got one leg shorter. Transverse rotation, as we call it, is an out-toed or in-toed gait. It's more commonly to see somebody with an out-toed gait. It's like Charlie Chaplin. They used to walk with an out-toe. And again, that means there's more force on the inner side of the arches of the feet. So there's a tendency for the feet to collapse. And so it's causing a problem. It might be at the foot, causing plantar fasciitis. It could be within the knee, the hip, even the lower back or the upper back. And then finally, joint laxity or hypermobility. And basically, I see many people where they're flexible. So you could add on a limb length difference, slight bow legs, and they're hypermobile as well. And that combined effect causes serious problems. Like this lad, well, sorry, your picture's in the way though. Just move. Can I do that?
Should just be able to, if you put your cursor over the people and the faces, you should just be able to move that.
Yeah, this is a person, as you can see, both feet are externally rotated, so that's out-toed gait. His right, this one, is more out-toed compared to the left. And also there is a slight leg difference. I don't know if you can see that, but the kneecap on the right is just slightly higher up than the left. So it could be that foot is slightly pronating more, or there could be an actual limb length difference. What's happened now? I can't move down.
Don't know.
I move that back. Very unusual.
You're trying to move your presentation on?
Yeah. Oh, there, it's working.
Time delay there.
So that's how. So when we talk about ligament laxity, you can be very extreme, and you can have what they call excessive elbow movement. So the child can do that, or the adult can do that. I see adults that can do that, where they can hyperextend the arm. They can have excessive movement around the neck. They can anteriorly rotate the pelvis. And one common complaint is they get pain in L4-5 or S1 round here, because remember the pelvis is anteriorly rotated. So it puts a lot of stress there. Obviously, they could do with Jason's advice, because this is where you need to improve the core stability to try to help the muscle groups to throw the pelvis back. They can have hyperextension of the leg or the knee. So the knee goes backwards, and that can cause anterior patella pain because the patella isn't able to track correctly. They can have excessive movement in the feet as well. So they might have no symptoms up here. It might be just in the foot. And that's this person that you're seeing here. I'm not sure, but that's how they would look if they had hypermobile feet. The foot would just simply collapse. In terms of management, or my management, is simply to try to reduce or limit the foot collapse or abnormal pronation. So all I'm trying to do is create a more normal limb. I'm trying to reduce any limb length difference, whether it be actual or functional. In other words, make the feet similar in profile, or if they've got one leg short, just simply raise it up a little bit, because that means then they're more equal on both sides. And by supporting the feet, you're reducing the mobility of the foot. So you're trying to create them, or trying to put them back into the normal position, like I was showing you that leg earlier on. So as part of my management, and part of the assessment is quite useful, is a gait assessment. That's walking on a treadmill, and that helps to identify any problems. And it also helps to show them, the patient, that they don't realize how bad they've been walking. Sometimes it can be a real obvious limp. It can be like a labored walk where they don't understand. They say, oh, well, I get tired if I walk too far. And it's because mechanically they're having to use more energy to walk because their gait is not symmetrical. They've got one foot collapsing more. And the research has clearly shown that you use more energy if you've got one limb working differently to the next. And if you go shopping, you'll see people walking like that. There's a lady in the Jolly Fresher in Lymm, and she walks terribly, one of the waitresses. I feel like going up to her and say, you need my help, but it's not very ethical. But basically, I take foot impression because these are bespoke, so we get a plaster Paris cast. The casts require cast preparation. It's called EVA, the material I use. It's ethylene vinyl acetate, and basically it's a hard material that you heat up and it's formed over their feet. The EVA is machined, and they can have 3/4 or 4 length orthoses, and the insoles are adjusted based on that initial assessment. And then finally, I'd just like to show you a few examples of minor issues that can cause problems. And this is like one of those games where you have to spot the differences between the two limbs. So if you look at this one, we've got a fairly nice curvature there. The foot seems to be fairly upright. But then we look at this foot, you can see there's an increasing curvature in the lower part of the tibia. And then you can see like there's some collapsing on the inner arch. This person might be fine again if they did some moderate work in the gym, doing weights, doing certain squats, things like that. But then if they start to do some exercises, they might get pain around here because that foot is collapsing. They might get some plantar fasciitis, they might get some shin pain, they might get some pain around the dorsum of the foot. And this is the same person. As you can see, I mentioned about bow legs. Now you can see here, there's some slight bowing. It doesn't have to be extreme, the bowing, but you can just see how there is some bowing. And sometimes you can have one leg more bowed than the other. And I think we have got this in this left leg, his left leg, compared to the right. And these are from a catalogue, by the way. So you'd think they'd get the socks the same length, wouldn't you? Hyperextension of the knee. So somebody with ligament laxity. Here you can see, you can't really see this kneecap, but you can see where there's an increase in hyperextension of that leg or the knee. And that can cause, as I said, pain around the knee. This is where devices sometimes help, or orthoses help, because it helps to support the foot. It's helping to realign that tibia. And sometimes that can help to reduce that knee hyperextension. This is completely opposite, which I haven't really mentioned at the moment, but this is somebody with a cavoid foot. And you can see that that right knee is slightly externally rotated compared to the left knee. If you look at the right arch, or the dorsum of the right foot, it's slightly increased in height compared to the left. But that, even the left foot, it looks like it's slightly pointing out or inverted. We've got what they call there a Taylor's bunion. You can just see that the fifth metatarsal is at an angle to the little toe, and the same goes there. So this is a young lad, and so that's going to get worse as he gets older. He could get pain around the sesamoid bones. We've got two little bones underneath the big toe joints. And because his feet are so high arch, it's quite common to get medial sesamoiditis, which is a sharp pain. And again, he might think, I'm going to do some running. But then after running a few miles, he gets his sesamoiditis. And it can be helped with insoles. And then, oops. So that's basically it. And that's what they call an onychogryphosis, thickened toenail with a horn-like shape. And that's the end of my presentation. Thank you.
If you'd like to make me host again, fantastic. Yeah. I'll get your contact details up. Has anybody got any questions for Neale?
I love the word onychogryphosis. It's one that I always remember from my college days, and it always comes up in a quiz, and I'm the only one who ever remembers it.
Yeah, that's very good.
It's really known as Ostler's toe.
Yes.
When the Ostlers looked after the horses, and the horses were standing on their nail bed, which ruined the nail bed growth, and it can grow like a ram's curly whirly horn. And
yeah, exactly.
To actually see them is just amazing, isn't it, really? And patients do have them, and they're awful to cut, so it's thank God you're around to deal with it.
When I first started in the NHS, I remember going to a poor old lady who was homebound, and her nails hadn't been cut for years, and all her nails were like that.
Oh my goodness, how did she walk?
She didn't really, so it took me about 2 hours to do the feet.
I bet she was walking on air afterwards.
Oh yeah, she's delighted. It's a shame.
But you know, sort of, I have orthotics. I have a short leg and an arch difficulty, and I work with Neale. He's helped me a lot. My work also has an effect on my body, and I'm very grateful for the help that Neale has given me, and also I work with Jason as well. I need a lot. I'm what you might call a high maintenance lady. They both help me.
Neale, I just had a question for you. I know you sort of spoke about people doing a lot more walking during the pandemic because we've not been able to do lots of other things. Does that mean that we should get our orthotics looked at on a more regular basis? Because I know last time I came to see you, you said mine had lost all their support and they weren't doing me any good whatsoever. And I was just thinking it's probably been 2, maybe 3 years since I had them, and with the increased sort of walking that everyone's doing now, do they need to, how often should you get them assessed?
Well, that's a very good point, because basically if you think about it, 2 years, 3 years ago, you might have had a certain pair of shoes that I said, oh yes, they're really good for the insoles or orthoses. 2 years later, you've checked shoe style changes, and so you believe that those insoles are still working well in the shoes. And I actually had a lady about 6 months ago. I made the devices, and she'd got these lovely soft shoes, and she was doing 10,000 steps, and she was in agony. And she said, look, Neale, your devices are not working. I said, well, no, it's not the devices, it's the shoes. Those shoes are too soft. So it's imagine the insoles need a firm base. That's number one. So they need a good quality shoe, which has got a firm base. So it's like the foundation of a house. if the foundation is moving around, the device will as well, so it won't work. And also material if you wear them a lot, I see people where they wear them every day.
Yeah, I wear mine every day.
They do start to need, sometimes they need just some minor mods, some adjustments just to increase the support, or sometimes they do need to be replaced. So I usually say they last about 2 to 5 years on average. I have had people where they've lasted 10 years, but it just depends on how often they're using them. And what some people do as well, they become pain-free, they've been cured, and then they put them away somewhere, or they think they don't need them and they throw them away. So your question is very good. It's precisely, yes, sometimes it's worth just paying the assessment fee or a review fee 2 years later just to get them checked out. And I might say, yes, I can do a small adjustment just to give them another year or two's lifespan. But in the end, they probably will need to be replaced at some point because fashion has changed. The prescription will have changed. It's like glasses. Our eyes don't stay fixed. We have to have them reassessed every year, every 2 years.
Okay, I'll wait for Willow to come home from university. She's coming home in the next 3 weeks, and then I'll probably get her and Ned and myself booked in to have an assessment. Before they start whatever they're doing after the summer. So I'll be in contact about that. That's great. Thank you.
Great, thank you.
Yeah, I think I might have a candidate for you. One with a fallen arch and a dodgy Achilles, who's doing a 10-mile run in October.
Yes, that's fairly common actually, where, like I said before, they start to do increase in exercise and activity, and then these issues start to flare up.
Oh no, he's always had the fallen arch, and the Achilles he did 10 years ago.
Oh, I see. Sorry, yeah.
But it just, I think every help helps.
Definitely. I mean, you can have the best running shoes, but that doesn't mean it's still not going to stop you from becoming injured.
Yeah, actually, I've got probably a question for maybe all three of you here, actually, because one of the things that I struggle with as a layperson is that how do you know when to go to whom at what point? Because when I only started running a couple of years ago, and I did the couch to 5K, and as Jason knows, I've not run for a couple of months now because of falling. But there was a guy who used to run with us, and he used to get tremendous problems with his shins. And I suggested that he went to see a podiatrist because actually I know one of your ex-students, Neale. My best friend's a podiatrist as well. And he said, oh, well, I'm seeing a physio. And he wasn't really interested. And I thought, well, if it's specifically your feet, then, maybe a podiatrist is better. But when would you go? If you've got a problem, particularly with your lower limbs, when should it be a podiatrist? When should it be a physio? When should it be Suzette? When should it be Jason?
Actually, that's a very good point, because I see quite a few patients where they've had 6-10 weeks of physio treatment and it hasn't worked. And then they come to me and I simply say, it's that and that. And the physio treatment would sort of work well with the use of insoles and things like that, because sometimes, as I said before, mechanically, or like Jason said, our bodies are mechanical structures, and so if there's a mechanical issue, that should be addressed, in my view, first, or in conjunction with other treatments. And this is a shame, really, that not Suzette, but I see some patients where they say to me, Neale, my feet are fine. I've been told by so-and-so that they're fine. It's not that, it's coming from my hips or my glutes or somewhere like that. Yeah. And that's causing the issue. And then I'm going, well, I'm sorry, but it's not. What's happening is that your feet or somewhere down below is affecting the glutes, and so they're not firing away as they should do. So it's which one do you believe first? And obviously, sometimes, this is why it's called musculoskeletal podiatry, but a lot of people just think they've got to go to the doctor. No, usually they see the doctor and the doctor says, go and see the physio. That's how it works. The doctors don't understand what podiatrists do. But the problem is, it's quite a speciality to make orthoses. I'm not trying to blow my own trumpet, but a lot of podiatrists, well, not to name names, but there's somebody else nearby to where the practice is in Knutsford. And I saw a gentleman last night, and he paid a lot of money and he couldn't wear them. He couldn't wear the orthoses because they were so bulky and so firm. And he said, I just need another pair of yours instead. And I'm not trying to wave my flag, but that's the problem. So some people get put off by podiatry because they think I paid whatever money, but it doesn't work.
Oh, I know that there's one here in Stockton Heath. It's a bit of, with corn, slice and come again.
Yeah,
it's not great.
Yeah, it is a big issue, and I've seen many people come along with a bag of insoles, and they've been recommended this and that, even the student. When I was lecturing, you can tell the students that were good at this, and there were usually only, I'm starting to say, one or two that really, because they found the machining scary, they found the biomechanics a bit. They just like to do not the routine, but the other side of podiatry. They like the diabetic podiatry, the rheumatoid podiatry, but it's quite a skill.
Yeah, and I think the diabetic podiatry is quite sexy because they get to do, quite a lot of gory stuff.
Yes, and they're working with diabetic consultants, and yes, it's more like treating people, with a team of consultants as well. But this type of podiatry that I do tends to be more private, and so because the NHS, if you go to some of the in Warrington wards, they've only got limited resources to actually make orthoses, and usually they just use some off the shelf where they do some modifications, which we used to call chairside orthoses at the university, which is very limited, and it's just a minor improvement, and it will work on some patients. But if I'm seeing somebody where they've got serious mechanical problems, you've got to go down the bespoke route. That's the problem.
Yeah, and I think you're very right. I think sometimes it's very hard you don't know when you've got a problem if you don't know you've got a problem, do you?
Yeah, it's usually the way it works with me is if they ever go to Suzette and suggest that they come to see me, or they've had a friend, the friend says, yeah, go and see Neale because it's worked with me. So that's how it usually works. So there are some other physios that do refer patients to me as well because they've had experience and it's worked.
Yeah.
So, yeah.
Sam, patients are very, very complex, and any therapist is a fool if they think they can just deal with it by themselves. And your feet are very complex machinery. When I was little, my parents always made sure they paid for the best shoes because in years gone by, they treasured their feet far more now than the shoes that are available, didn't they, Neale?
Yes.
We had Start Right, supportive, shoes for young malleable feet. And last week I had a young lad who has been going to a massage therapist who has for the last 3 years, and she's beginning to realize she's not helping him, so she's referred him to me, and I've referred him straight to Neale and also to a spinal pediatrician consultant because he's got a true leg length difference, and he stands with one knee bent to adjust for the short leg. But not only has he done that, he's rolled over on both feet, pronated, and he's at the age of 15, his knees are worn out because he loves playing football. So discussing with Neale, because he wants to play football, can then refer him to, as well as addressing his leg length difference, can refer him to a football boot specialist who can probably help with making the right kind of football boots to, help him to play, because if you really love doing something, in my book now, even though you might be doing physical harm, the actual mental enjoyment of doing something is so positive to your body in so many other ways.
And what I find is that patients or sports people are quite happy to buy a really expensive bike, 8,000, 10,000. They become, you know, they want to do this running and the cycling, but then they don't think about the mechanics of their body and whether they might spend another £500 to have that bike set up for them, but they're still not thinking about themselves. And we're so used to the NHS, we're so used to going to the doctors telling us, actually there's a doctor's program where it's all about GPs and people popping in. And it's surprising, there was a GP, a child who came in, got lateral ankle pain, and the GP was simply saying, it's a sprain, it'll get better. And when I was watching this and the child walked out, he'd got quite a severe outside gait. And I would imagine it's not a sprain, it's actually the foot rolling over. So there's a need for people to understand that, you know, assessment, it might, you know, what's half an hour of assessment just to get your foot checked over or your lower limb checked over. And that's what I think should be done. But we are so geared towards going to the GP or geared to going to a physio. That's the medical model at the moment, unless they hear about Suzette, which many people do, and you know, get referred on to myself.
We do try our hardest to shout loud about Suzette and Lymm Osteopathic practice.
We, you know, like you know, structure governs function, and it doesn't matter, you know, what part of the body. It's always looking for the cause and never treating, you know, the symptoms, and looking at, you know, people holistically. But I think GPs know nothing about musculoskeletal. They don't even. I think they do a day's training in their university, you know, training course. So that's why they feel just pass it on to the physio. So if you go to the physio and it's a good physio, then you're lucky. But if it's not, you know, for most patients who come to me, they just get a set of exercises.
Yeah.
They get, you know, sort of a sheet of exercises, and the physios never assess them or, you know, sort of gone through the exercises with them. So you've got to have a little bit of nous and education yourself to want to help yourself these days, I think.
Sharon, can
Yes.
I just, not to be funny now, but you spelt Browne about the
I
ear.
have, haven't I? I'm so sorry. I just noticed
noticed
that myself. Let me see if I can go and change that for you while we're live. Can you see that? I'm not sure whether I'm still sharing my screen or not.
You're not.
I'm not.
But just going back to what Suzette said about physios, I see quite a few patients where they've been given these exercises by the physio, and sometimes it makes the condition worse, especially with Achilles tendonitis, because if some fibers torn, like Jason said, yes, do some exercises, but not, you know, some of the patients I see, they're doing these exercises 3 or 4 times a day because they believe it's going to get them better. And instead, it makes it worse because all they're doing is doing further damage. So this is, and I had one patient and she just had a Zoom meeting with the physio, and the patient had to set up the camera so that the physio could see her walking up and down her living room. And then from that, the diagnosis was made and the exercises were given.
Wow.
I'm not trying to poo-poo physio, but I know because of lockdown, it's very difficult. But I would, yeah, it's a bit concerning that GPs are doing this as well, where it's becoming a Zoom meeting of treating and diagnosing. It's a shame. And I understand for their precaution, but I think hopefully things will change for the better when they see patients again.
I think we're very lucky at my practice because all the people who work with my practice are a great team of people who care about the patient, want to help the patient. And the kind of people that we get are people who want to know about their bodies. And then it's great fun, and it's so interesting for us to actually explain and help them, and to help to put them in a place where they can be empowered and get on with their life. And you know, that's what I think it's all about. You've done a good job, and you know, sort of because the body is so complex, you know, sort of a lot of patients will, you know, I'll start the assessment, Sam, you asked that question, and you know, sort of I'll have noted whether they needed to see Neale, or you know, I'll do the best I can for them. And you know, I send them to Neale when they may have just had to settle their back down a little bit, so that you know, they can take the change if they, you know, with Neale before, because if they're inflamed and in great pain, to then have an adjustment to their arch can be, you know, very painful for them. And then when I, you know, sort of got them aligned, you know, sort of, I just think it's so wonderful to have Jason on my side, because then, you know, he can, you know, sort of help to keep them supple and give them the benefit of his training with exercises. So it's what patients want. It's what patients, how much they want to be empowered and how much they want to live their lives. It's, you know, the cue is from the patient. You know, most patients come in and say, oh, for God's sake, just get rid of this pain. And they think, you're wearing the white coat, you should do all the hard work. It's not that simple, really. You know, sort of you have to reach them through their mind to make them understand what's going on, to allow them to help themselves, really. It's empowering them to take charge.
Yeah. Yep.
Sorry, I talked too much.
we are just about to finish, Sam. I just wanted to thank both of our speakers for coming along tonight, and just let you know about the next talk, which is taking place on the 13th of July, where we have Fiona, who's talking about menopause, and she's going to focus on things like mood swings, hot flushes, insomnia, weight gain and anxiety, and how we can deal with all of those symptoms in a better way than just taking medication. So that's on the 13th of July and will be at 7:30. So I look forward to that. I'm going to stop recording now. So thank you for everybody for coming along, and we hope to see you next month.
Sharon, can I talk